want to know that, again, what I've said, that urine in these patients, urine will be, yes, will be dark colored and stool will be light colored. With that, because there is cholestasis, bile acids also go to the circulation and bile salt, and they produce severe itching. So there's a lot of excoriations or itching. So when you jaundice patient with itching and dark colored urine and light colored stool, it is definitely a case of cholestasis. And usually in cholestasis, if it becomes prolonged, a lot of cholesterol is retained in the body, and this cholesterol may produce special yellowish plaque under the skin. We call them xanthomas and xanthelasmas. Xanthomas. So what did we learn? That in 4 and 5 cases, when there is obstructive jaundice, most important finding is urobilinogen absent from urine and conjugated bilirubin present in urine and conjugated hyperbilirubinemia, and markers of canalicular injury appear first in the blood and in very high amount, and markers of hepatocellular injury appear late and less in amount. Am I clear? Now, after having said all of this, now how do you differentiate really cases of 4 and 5? Is it intrahepatic obstruction or extrahepatic obstruction? Very easy. What will you do? Just do ultrasound. If you do the ultrasound and you find common bile duct dilated, it is extrahepatic obstruction. In this case, right, you go for ultrasound, and ultrasound can tell you if common bile duct dilated, then it is extrahepatic cholestasis. But if common bile duct is normal diameter, then it is intrahepatic obstruction. If there is intrahepatic obstruction, then bile is not going to common bile duct, so it will not be dilated. But if there is, suppose, what is here, papillary carcinoma, or there is carcinoma of the head of the pancreas, or the common bile duct carcinoma, or there is a gallstone, a stricture, or atresia, all these things will produce what type of problem? Dilated what? Common bile duct. Is that right? So, extrahepatic biliary system, if it is dilated, you must think of extrahepatic cholestasis. If they are not dilated, we must think of intrahepatic cholestasis. The next investigation which is important, that if you find that there is extrahepatic, what is there? If there is extrahepatic cholestasis, the next investigation should be ERCP. ERCP. What is ERCP? Endoscopic retrograde cholangiopancreatography. What you really do is that you pass a catheter from here, endoscope from here, and this endoscope is going, and it is side viewing endoscope. Through this endoscope, you have taken the endoscope through the oral cavity to the esophagus, pharynx, esophagus, and then to the duodenum, through the stomach and duodenum. Then this is a mirror, you can say, which can view on the side viewing duodenoscope, we call it, and it will locate ampulla of Vater. When it will ampullate, then we bring a catheter out of it. What do we bring out of it? A catheter, and we engage the catheter into papilla of Vater, and then we put a radio opaque material, so it can lead to, and then we take up the X-ray, so it can show the pancreatic duct as well as it can show the common bile duct, and not only it can show the anatomy of that area, but it can show the level of obstruction as well. Is that right? We call it ERCP, endoscopic retrograde. We are going retro. This is going retrograde, endoscopic retrograde cholangiopancreatography. Endoscopic, then retrograde. It's going in retrograde fashion, right? It's pushing the dye in retrograde fashion. Cholangiopancreatography. Is that right? And another advanced form which has come here, and that is replacing the ERCP as you can say investigative tool, that is MRCP. MRCP test. What is MRCP? Magnetic resonance. Magnetic. It is something like MRI. MRI taking the information about the common bile duct and the ductal system. So we call it magnetic resonance cholangiopancreatography. These days, this investigation is replacing, wherever it is available, ERCP for its diagnostic functions, but not for its therapeutic functions. Now, we come to this patient who has common bile duct problem. What you will do with this patient who has common bile duct problem? Common bile duct is normal. It means there is problem intrahepatic. If there is intrahepatic obstruction, what type of investigation will you do? The next? Yes. What is that? PTC. What is PTC? Percutaneous transhepatic cholangiography. Percutaneous transhepatic cholangiography. What you really do in this case, that in the mid-axillary line, first you percuss out the border of liver, right? In the mid-axillary line, guided by ultrasound, you push a needle which should end up into some dilated radicle of biliary collecting system, and there you inject the dye to visualize it. If all these things fail, you are left with only to do liver biopsy. You're supposed to do liver biopsy. Again, let's come back. Now I'll ask you a question. If a patient comes to you, there's a patient who comes to you, and patient is having severe itching. There's a young female, severe itching, some xanthomas, conjugated hyperbilirubinemia, right? No urobilinogen, lot of bilirubinuria, dark urine, light stool. What type of jaundice is this? Obstructive jaundice. AST, ALT are mildly raised, and alkaline phosphatase, 5-nucleotidase, and gamma glutamyl transferase are severely raised. So what is this? Obstructive jaundice. Now in this patient of obstructive jaundice, when you do ultrasound in this lady, common bile duct is not dilated. Is that right? If you do some autoimmunity profile, you find anti-mitochondrial antibodies very high. What do you think? Anti-mitochondrial antibodies are associated with primary biliary cirrhosis, autoimmune process which attack the biliary system. Is that right? Another case, patient come, and patient is very much pale and jaundice. Pale mean hemoglobin is low, and icterus mean yellow color is there, right? And patient has strong history of blood transfusions previously due to, he has been receiving blood transfusions due to severe anemia. Is that right? His spleen is enlarged. Coombs test is positive against the RBCs. It means the RBCs are coated with autoantibodies. Is that right? Unconjugated bilirubin is 5.5 milligram per dl, right? With little increase in total. Urobilinogen in the urine is more than normal. Stool is dark colored. AST, ALT normal. Prothrombin time normal. Serum albumin normal. Alkaline phosphatase normal. Ultrasound shows normal ductal system and ductal anatomy. What do you think? This is extravascular hemolysis, because splenomegaly was there. It was extravascular hemolysis. Now I will ask one more question. If a patient has come to you and patient has complained of, listen carefully, patient has severe anorexia, nausea, low-grade fever with upper hypochondriac pain for many days. Patient has developed jaundice in which total bilirubin is high, conjugated is also high, unconjugated is also high. There is a mild to moderate increase in alkaline phosphatase, serum alkaline phosphatase, and gamma glutamyl transferase and GGT, and 5-nucleotidase, and there is very high AST, ALT. What's wrong with him? There is hepatitis. And in this patient, you find that hepatitis B surface antigen is positive, as well as hepatitis B E antigen is positive. What is diagnosis by now? Very clear. Acute We cannot say is it acute or chronic. If it is less than 6 months, it must be considered acute. If it is more than 6 months, then it must be considered chronic. Is that right? Because in hepatitis, cutoff point is that evidence of liver injury is less than 6 months or more than 6 months. If it is less than 6 months, it should be considered acute. And if markers of liver injury or history is showing problem related with the liver is more than 6 months, then it is chronic. Is that clear? Okay, I will give you one more case. Patient is brought to you and patient has severe weight loss, severe anemia, severe abdominal pain, right, especially radiating backward. Patient has pale colored stool and steatorrhea, dark colored urine, no urobilinogen there, AST, ALT slightly raised, serum alkaline phosphatase very much raised, conjugated bilirubin very much raised. Now, but it is obstructive jaundice. But there are special things I've said. There's an old man in this case. There's an old man. Number one. Number two, there's very significant weight loss. Number three, there is severe pain in the abdomen radiating backward. It's very good. Carcinoma of head of pancreas. Cancer of head of pancreas. But if same patient having lot of occult blood appearing into fecal matter, then it is probably carcinoma of ampullator. Is that clear? Any question here? Any question? No question? Last discussion.